Yeah, I'm very actually honored and humbled to be able to present this to such a distinguished crowd and to folks that have really thought about these kinds of problems. The subject of what I'm going to talk about is using HTA to inform not the price of drugs but the price of fees, which was sort of done. We did this in tandem with the pharmaceutical pricing. Thought it'd be interesting to look at. So again, everybody has heard about the increasing expenditures this morning. Some recent reports internationally about health systems have really sort of talked about opportunities for gains in efficiency. So if we think that there aren't opportunities for gains, I think these reports have sort of shed some light on that, and particularly the use of medical technology, health technology not going away. It continues to be a source of expenditure growth. And if you think about providers and about sources of expenditure, providers and hospitals are sort of main contributors. And when a provider makes a choice about the types of medical technology that they want to use when they're providing a service, that they're kind of sort of providing a double whammy, which is sort of inducing hospitals to use certain types of technologies and at the same time being paid for the service. So I think it might be opportunities here. So currently in Canada, for the most part, provider fees are cost-based. There's formulas and they differ across jurisdictions for how the actual price of a fee gets put together. But at the end of the day, for the most part, physicians can provide similar services using potentially different procedures. So a physician can do a surgery in two different ways, percutaneous or open procedure. And the value of the service, the value in terms of efficiency gains, whatnot, to the health system are not really are factored into the price of the service. In addition to that, we see that when provinces are or insurers are very uncertain about cost effectiveness or effectiveness, they may decide not to develop a fee code for a particular service, or they may say it's experimental, and that sort of almost amounts to sort of not insuring or saying that they're essentially modifying the price to zero in that case. And so the lack of this kind of standardization also provides opportunities, because this is being done in each province, and we have these disparate health systems in Canada, for whipsawing, which is a fee we may have a fee code in one province, and the providers in another province say, well, like, I want to be like my fellow surgeons in BC. Don't make me move there. And so we call this whipsawing, and I thought I'd illustrate that and provide an opportunity to show my children. They both have Cars pajamas on, even though we bought them for the 5-year-old boy. The 3-year-old girl took it upon herself to sort of protest for a week until she too had Cars pajamas. She doesn't need Cars pajamas. We actually had to spend extra money to get the Cars pajamas. It made her a lot happier. So equity. Equity is an important thing in my house. And whipsawing is something that we'd like to overcome. And we've seen other policy mechanisms in place to overcome this, particularly the Common Drug Review, the Pan-Canadian Oncology Drug Review, mechanisms that are put in place to look at value, but look at it all at once, to coordinate. And we heard a lot about that in previous discussions. So right now it's a disconnected system for the most part. There's an interprovincial territorial medical forum of medical directors. They sort of loosely connect and they talk about things, but it doesn't have any particular function. They compare notes, essentially. And what we proposed is something we think is feasible and desirable, and that is a pan-Canadian approach. I'm saying pan-Canadian. I'm not saying a federal government approach. I'm not saying an Ottawa-based approach. I'm saying a pan-Canadian approach that really has its governance in the provinces. So similar to what we've seen, for example, with something like Common Drug Review or PCODR. And this pan-Canadian approach could develop a standard method for taking each information and creating price modifiers. And so I'm going to skip to this slide to give you an example of what a price modifier might be. So we have a technology, and in the first row we have sort of what happens in a world where we don't have modifiers. And we see the total healthcare costs. We have similar services, different technologies, and the total healthcare costs total up to maybe a couple of $1 million. If we apply modifiers, not only do we change the price of the service that the price that we're willing to pay, but we could also potentially affect utilization, assuming that physicians would be incentivized to be paid more, which I think there's sort of sufficient literature to say that does happen. So we see in this particular case, just by modifying a couple of fees and shifting utilization ever so slightly, we could get a net saving. And yet, if you actually compare sort of what happens to the physician fees, they're making sort of a lot more doing the sort of high value procedure because they're being paid more and they're doing more of them relative to low value procedures. So physicians don't lose, society doesn't lose. It's an optimal situation. There are other functions, though, that such a body could provide a platform of opportunity for example, providing a standard approach to assess the value of new fees. We see actually in our neighbors to the south, they do have standard national approaches for social insurance programs for looking at and evaluating new fees. They've also developed what are called resource-based relative value schedules, building in other sources of relative value according to demographics. Do we pay a physician in Toronto the same that we pay a physician in an area of the country where it's much less costly to live? So they've developed these standardized systems. And so this gives us an opportunity to create standards. It has a lot of benefits, potential benefits, including reducing inequity, reducing unnecessary political pressure, and we can influence providers to potentially sort of do what's best for the health system. And we hear about fee-based utilization effects and what have you. And I think with something like this, we're not going to see something like this create. I mean, if there is such a thing as, for example, supplier-induced demand, this idea that you claw back and the physicians will take it somewhere else. Well, the idea here is they'll take it from, if they're getting paid less for the low-value service, they'll take it from doing the high-value service. So we're trying to actually work with this idea of inducement. And then you have opportunities now to have more coordinated pan-Canadian technology management and also look at health and human resources from a pan-Canadian basis. I think it's something that happens informally now, but this would formalize it. I'm going over time. The challenges, we've talked about, how would you then look at value, high value versus low value? That's always a challenge. You couldn't look at every new fee, every service. You'd have to decide how you'd look at those because it's actually costly to set up an evaluation system, et cetera. And we already have variation in current fee schedules, so there'd be some coordination challenges similar to what we heard with value-based pricing of pharmaceuticals. So a recommendation, a coordinating body, provincially governed, to standardize and look at new fee value-based modifiers. And that's it.